Pituitary tumor syndromes begin with mass effects and hormonal dysfunction. These lesions arise in the sellar and suprasellar region and affect multiple neuroendocrine pathways. Headache is a common presenting symptom. It may occur even in small pituitary microadenomas. Optic chiasm compression leads to visual field defects. The classic finding is bitemporal hemianopia progressing to blindness if untreated. Cavernous sinus invasion causes cranial nerve palsies. Third, fourth, and sixth nerve involvement leads to diplopia, ptosis, and ophthalmoplegia. Fifth, cranial nerve involvement causes facial numbness. Hypothalamic invasion leads to temperature dysregulation, obesity, and behavioral changes. Diabetes insipidus may occur due to hypothalamic or pituitary stalk involvement, patients present with polyuria and polydipsia. Skull base invasion can cause cerebrospinal fluid rhinorrhea and nasal obstruction. Rarely, seizures and personality changes occur. Magnetic resonance imaging with gadolinium is the gold standard. It evaluates the pituitary gland, optic chiasm, cavernous sinus, and suprasellar region. Computed tomography detects bony erosion and calcification. It is useful for surgical planning and tumor characterization. Pituitary adenoma appears hypointense on T1 and hyperintense on T2 imaging. Craniopharyngioma is cystic and calcified with suprasellar extension. Perimetry is essential for visual field assessment. Early detection prevents irreversible optic atrophy. Laboratory evaluation depends on tumor function. Prolactin, insulin-like growth factor 1, thyroid-stimulating hormone, cortisol, and gonadotropins are assessed. Cushing syndrome evaluation includes 24-hour urinary cortisol, overnight dexamethasone suppression test, plasma ACTH, and late-night salivary cortisol. Acromegaly is diagnosed using elevated insulin-like growth factor 1 and failure of growth hormone suppression after glucose load. Non-functioning tumors require screening for hypopituitarism. Cortisol, thyroid hormones, sex hormones, prolactin, and insulin-like growth factor 1 are measured. Immunohistochemistry confirms tumor subtype and hormone secretion. It is essential when imaging and laboratory results are inconclusive. Medical therapy includes dopamine agonists for prolactinomas and somatostatin analogs for acromegaly and TSH-secreting tumors. Targeted agents are used in specific cases. Radiation therapy is used for residual or inoperable tumors. Options include stereotactic radiosurgery, fractionated radiotherapy, and proton beam therapy. Craniopharyngioma is often cystic and calcified. It requires surgery and often radiotherapy, with high recurrence risk and lifelong hormone replacement. Rath cleft cyst is treated with surgical drainage when symptomatic. Pituitary metastasis is managed by treating the primary cancer. Follow-up requires lifelong monitoring of hormone function, visual fields, and magnetic resonance imaging for recurrence. Clinical management requires a multidisciplinary team including endocrinology, neurosurgery, radiation oncology, and ophthalmology. Treatment is individualized based on tumor type and invasiveness.